So with that, again, I want to thank you all for joining us today. And I can see folks are already chatting in using the chat box, so thank you so much. And with that, I'm going to pass things along to Katie Merrill, the Director of Rehabilitation Services, as we go to the next slide.
Thanks so much, Meg. Hi, this is Katie Merrill, Director of Rehab Services here at OMH, and I'm very excited to be here talking to you all about Core Services Peer Support. As many of you may know, peer support has been our most popular of all of the behavioral health, home, and community-based services, and we expect that there will be very high demand for this service under Core. So we want to make sure that everyone is starting out with a solid understanding of what the service definition and components are, what some of the changes are from BH HCBS over to Core Services, who can deliver the services and supervise the services, and then we'll wrap up today with a case example. So I guess we'll just dive in and hopefully have time for questions at the end. Next slide. All right, so hopefully many of you have had an opportunity to look at the Core Services Operations Manual that includes the updated service definition and components. If you haven't, I really do encourage you to read through the Operations Manual. What you'll see there is that we've actually made some changes to the definitions and components, and really we're just updating our language and incorporating our lessons learned through oversight and technical assistance. We've spent the last 5 or more years working directly with providers across the state to learn what works well and what hasn't worked so well. And we wanted to show as much of that and showcase best practices through the operations manual so that everyone could really understand the strengths of these services and how to use them. We also wanted to give peer specialists the language that they could use in progress notes to really describe what the Medicaid billable services are that they're providing. So we were more descriptive in our service components, really showing how an individual could use their lived experience to support another individual in their recovery. Next slide. So I'm just going to give a very brief overview of some of the key changes from BH HCBS to Core under peer support. And then Stephanie and Amanda from my team will go through the details. So overall, some of the big changes, I already mentioned that we incorporated some new language in our definition and service components, and we really wanted to highlight key concepts and values for peer support, including resilience, self-efficacy, hope, and shared lived experience. So as you read through the manual, you're going to see those key themes repeated and really illustrate how staff can use those concepts to support people. We also have a new component, person-centered planning, documentation, and collaboration. This is the first component listed under peer support, and what we wanted to do here is capture the importance of person-centered planning. We wanted to show how through collaborative documentation, you can engage the individual in a meaningful process while also getting a billable service out of it. And then the collaboration piece is so important because it allows peers to collaborate with other collateral or individuals who are identified as important to the individual. So that could be their family of choice, it could be a staff in their housing program, it could be their primary care doctor or their care manager, anyone that that individual has identified as important to their recovery and someone that they would like to be in contact with their peer specialist. So this new component we really see as supporting integration of the peer support service in the larger service system and ensuring that individuals are able to access services along with their family of choice. We also wanted to promote role clarity. So we know that there's sometimes confusion around what the role of a peer support specialist is. And at times we've seen that they can be treated as more of a case manager or care manager. And so we hope that the updated definition and updated language provides more clarity on what exactly the peer specialist is doing. We've made some changes in access to all of the core services. So this isn't specific just to peer support, but all of the core services are now easier to access. And that's going to promote upfront engagement of the individual. So you no longer need things like the eligibility assessment or a referral from a care manager. You can, as long as you're an eligible individual, actually make a self-referral. And we think that this is going to help with engagement. And lastly, one of the key changes I want to talk about is the elimination of the annual hours cap and the daily unit limits. So any of the caps and restrictions that were on these services, we've actually lifted. We want people to make person-centered decisions around how much service is appropriate. Now, we do have recommendations for how many hours or minutes in a day might be appropriate, but that can be exceeded for reasons of medical necessity, and we're going to talk about that a little bit later. But what you do need to know is the annual hours cap has been eliminated. So where it used to be set at 500, there is no longer an annual cap. All right, so with that, I'm going to turn things over to Stephanie, and she's going to get into some of the details around the service definition and components.
Thank you, Katie. My name is Stephanie Rodriguez from the Office of Mental Health, and I'm going to walk you all through the definition and components for peer support today. Next slide, please. So we need to go over the service definition before we can even get to the components. So empowerment services or peer support are non-clinical, peer-delivered services with a focus on rehabilitation, recovery, and resilience. They're designed to promote skills for coping with and managing behavioral health symptoms while facilitating the utilization of natural supports and community resources. Next slide, please. A peer support must include the identified goals or objectives in the person's individualized service plan or ISP, with interventions tailored to the person. These goals should promote utilization of natural supports and community services, supporting the person's recovery, and enhancing the quality of their personal and family life. These intentional, goal-directed activities provided by this service emphasize the opportunity for peers to model skills and strategies necessary for recovery, thereby developing the person's skills and self-efficacy. These services are provided through the perspective of a shared personal experience of recovery and enhancing the person's self of empowerment and hope. Next slide, please. There are 6 components when it comes to peer support, and I'll read through them all briefly on this slide, but we are going to go into more detail on the upcoming slides. So the first of which is person-centered recovery planning, documentation, and collaboration, advocacy support, activation and engagement in recovery, community participation, transitional support, pre-crisis, and crisis support. Next slide, please. So the first component we're going to talk about is person-centered recovery planning, documentation, and collaboration. This component utilizes shared decision-making around service and recovery planning. The peer reviews progress towards goals and objectives, updating the ISP's goals are met or other changes are needed, and can communicate with other providers such as prescribers, treatment providers, case managers, or even employment specialists. And this is to ensure integrated and collaborative care. Next slide, please. Advocacy support. Now, this component does not replace the role of a care manager or care coordinator. Instead, the peer supports the person's self-advocacy during appointments, and the peer raises the awareness of existing services and community resources, connecting the person to warm lines and peer-run groups in the community. Now, these community groups can be in person or online. A warm line is typically a telephonic or virtual service for people who are looking to discuss their daily struggles. They are often staffed with self-identified peers, and they listen and offer support, share their experiences, and offer up more community resources. The peer works alongside the person as they seek and obtain benefits and entitlements, food, shelter, and permanent housing. The peer advocates on behalf of the person while keeping the person informed of all decisions and choices made. Next slide, please. Activation and engagement in recovery. So this component is all about validating and empowering the person. The peer is able to relate their own recovery stories to what the person may be going through at the time. The peer models the recovery lifestyle, and this can include participation in recovery activities that might be beyond the scope of treatment providers. They also can offer wellness coaching, which is a focus on whole health, and this can include discussing and sharing ongoing personal efforts to enhance health, wellness, and recovery. And they're also able to use self-directed recovery tools, such as Wellness Recovery Action and Planning, or WRAP. And they're able to celebrate the efforts and accomplishments with the person as they go through their recovery journey. Next slide, please. Community participation. This component is all about exploring the community. The peer supports the person in attending community activities and appointments when requested, and can also support skill development for a more independent life in the community. And this can be something such as taking the person to their bank, teaching them personal banking skills, or teaching the person what public transportation is available in their community. And this promotes integration and inclusion, as well as assists in creating long-term natural supports in the community. Next slide, please. Transitional support. Now, transitional support is based on the peer bridger model. Peer bridgers are trained to support people with major mental health or addiction-related problems to make successful transitions from OMH psychiatric centers and state-operated community residences to their communities of choice. Their main focus is to assist people to improve their health and meet their personal and community goals, while reducing avoidable crises and readmissions. They're also able to engage a person after discharge from, let's say, a hospital, emergency department, inpatient detox, inpatient psychiatric unit, or residential treatment. And they're able to link the person to care, thus helping with community tenure. Next slide, please. And the last component is pre-crisis and crisis support. This is a non-clinical support to a person who is currently in distress or crisis. The peer is able to accompany, support, or advocate on behalf of the person in an emergency room or crisis unit or any other service to help assist with their current crisis. They're also able to assist the person in the moment with putting their wellness crisis or even recovery plan into action. They're also able to provide short-term post-crisis support. Next slide, please. And a brief summary of some examples of what core peer support could be used for is, like we said, sharing a personal recovery story to instill hope for the future, support the person in connecting with mutual aid groups in the community, and this can be AA, NA, using My Psyches to support a member's shared decision-making skills, and provide reassurance and support to someone who's currently in distress or crisis. Next slide, please. And with that, I'm now going to pass it over to Amanda, who's going to take you over qualifications and training.
Thank you, Stephanie. My name is Amanda Pomain. I am with the Office of Mental Health. Next, we will be reviewing the necessary qualifications and training requirements to provide peer support through CORE. Next slide, please. Staff and supervisor qualifications. Peer support is delivered by certified peers under the supervision of a qualified supervisor. For the Office of Mental Health, this will be delivered by a certified peer specialist, including those who are provisionally certified. And for the Office of Addiction Services and Support, this will be delivered by certified recovery peer advocates, including those who are provisionally certified. Qualified supervisors include certified rehabilitation counselors, CASAC advanced counselors, licensed creative arts therapists, licensed psychoanalysts, licensed psychologists, licensed marriage and family therapists, licensed health counselors, nurse practitioners in psychiatry, physicians assistants, psychiatrists, registered nurses, and/or a licensed master social worker and licensed clinical social worker. Agencies may choose to implement an administrative or task supervision model in addition to clinical supervision. Using this split model for supervision helps create a career ladder for certified peers and other unlicensed staff. Next slide, please. Training and workforce development are critical to the success of core services. Both staff and supervisors are required to complete modules in psychosocial rehabilitation, person-centered planning, motivational interviewing, shared decision-making, trauma-informed approaches, and wellness self-management. Next slide. An additional required training for peer staff and supervisors is the application of principles core peer support. This training and the trainings listed above will be hosted on the Center for Practice Innovation Learning Community, an online learning management system. The timeframe for completions of all the above mentioned trainings are outlined in the staff training memo. Next slide. Service delivery is provided through the perspective of a shared personal experience of recovery, enhancing an individual's sense of empowerment and hope. Next slide. Services are delivered with respect to an individual's preferences regarding days, times, modalities, and locations that are convenient for them and best suited for their desired outcomes. Peer support is offered one-to-one only and may be delivered via telehealth and telepractice. Next slide.
And Amanda, before you continue, we're just getting a couple chats that the audio is muffled. So if you could maybe speak a little bit closer to your microphone piece, I think that's the best way we can remedy that in the moment. Thank you, Amanda.
Sure, my apologies. How does this sound?
That sounds a little bit better. Thank you.
Great. Intensity and recommended unit ranges. The scope of intensity of core services should be based on the level of support needed to support the individual in achieving their recovery goal and sustaining recovery. Recommended unit ranges have been developed to illustrate the scope of service and program design. Next slide. The recommended unit range for peer support is 1 to 16 units that are 15 minutes in length for a total of 15 to 240 minutes. Next slide. ISPs should be developed utilizing these recommended ranges and do not apply to an individual in crisis, although the crisis should be clearly documented in the progress note. The unit ranges may exceed when a short-term increase in intensity supports the goal acquisition. Outside of crisis situations, the decision to exceed the recommended range should only be made in consultation with the clinical supervisor. Next slide. To promote role clarity, peer support is not case management, personal care services, or a replacement for custodial care in an institutional setting. Peer support is intentional and goal-directed with a focus on developing the individual's skills and self-efficacy. I will now be handing this back over to Katie, who will be continuing with the summary and case examples.
Thanks, Amanda. Next slide. So I just want to share a case example, and this is actually drawn from an individual who received BH HCBS peer support. One of the wonderful things about our doing technical assistance and oversight is that we've been able to see and hear about the many great things that peer support has done for HARP members, and this case in particular really highlighted the value of a peer support specialist. So Maya is an individual who lives in an apartment treatment setting and is working on a goal of moving to more independent housing while actively engaging in her community. She spends most of her time in her apartment and has trouble accessing the community without support. At her residence, the apartment treatment staff are able to provide transportation and support with things like grocery shopping and medical appointments. But this individual had acute anxiety when she went into the community alone. She doesn't have a vehicle and prior to receiving peer support, had never accessed public transportation. So the thought of going anywhere further than a couple of blocks is pretty overwhelming to her. Next slide. Maya's housing case manager was able to refer her. We have core peer support. As I said, this was a real example of someone who received BH HCBS peer support. Referred her to peer support to focus on increasing her access to the community. So the peer specialist engaged Maya through person-centered planning and learned that she really loves cultural events and venues, things like concerts and museums, the art community. So together they began riding the bus, and Maya learned to navigate different routes and manage her anxiety in public settings. She was able to learn how to transfer on the bus, and eventually even got a half-pass bus fare, so that she was able to navigate the public transportation system more affordably. Her peer specialist was able to share stories from his own recovery to increase her hopefulness and her resiliency. As I mentioned, she was able to get the half-pass bus fare and learn the route from her home to the downtown library and local museums. Through peer support, she made significant increases in her confidence and now enjoys time in her community more frequently, both with her peer and independently. Next slide. Through this example, and I'm seeing a typo right there, of course, why peer support worked for Maya, not family support and training. I apologize about that. First of all, the service was complemented by the work being done at the apartment treatment program. So the staff at the residence were able to support with things like grocery shopping and medical appointments. But at that level of service, they really weren't able to engage her around cultural events and going to museums and riding the bus. So the peer specialist was able to work collaboratively with the housing providers to increase her community engagement. They used person-centered planning to learn what types of community events and locations would be of interest to her. So they were able to identify those museums and libraries and events like that that would really highly motivate her to want to go out into her community. And she was able to receive support from someone who's been there, who could talk her through managing that anxiety in public transportation or in community locations. And lastly, they were able to support her in accessing a community resource, the half-pass bus fare, that supported her goal acquisition so that she was able to do these things independently over time. All right, last slide. So we've moved through these pretty quickly. I'm going to just go over some brief highlights, and then we'll turn it over to your questions, which I see are piling up in the chat box. Peer support is an a la carte peer support service, which means that it can be provided as a standalone service or as part of a customized service package. So what does that mean? Perhaps you have an individual who's ready to step down from an ACT program or from a PROS program, but they still need some support with achieving their goals. You might look to do a combination of something like peer support and psychosocial rehabilitation, so a customized package where that individual could continue to receive support, but perhaps at a lower frequency or a lower intensity than they may have received in ACT or PROS. You could also pair a peer support specialist with something like outpatient clinic services, or use any of the core services and provide them in a bundle. Peer support services are provided through the unique lens of personal, shared, lived experience. So peer specialists have lived experience of mental illness or addiction, or they are the close family member of someone with an addiction disorder, and they're able to use that experience of recovery to support individuals in pursuing their own recovery. And that's really what makes peer support unique and different from a service like psychosocial rehabilitation. So the individuals who benefit from peer support are those who want to receive services from someone who has been there and who knows what it's like to navigate the system and achieve recovery. Peer support promotes the inclusion of the family of choice and other collaterals to promote integration, coordination, and involvement of natural supports. So I mentioned earlier that you can now bill for time spent talking to identified family of choice or collaterals. That would include other service providers if the individual has identified them as important to their recovery and achieving that goal. And we really want to see peer specialists better integrated into our system and able to work collaboratively with, say, housing providers or clinic clinicians to support people in achieving their goals. And lastly, in peer support, you're going to see an emphasis on community participation. And that includes things like the peer bridging interventions that we talked about earlier, where peer support specialists are able to support individuals who are coming out of hospitalizations, institutionalization, perhaps they're moving out of a psychiatric center or a community residence, or coming out of prison and jail. So that's a really exciting opportunity for peer support to be provided to individuals who are really at an acute point in their recovery, and where these services could support them in achieving long-term stability and longevity in the community. And with that, next slide, I think we can open it up to questions.
Well, thank you so much to all of our state partners who just kind of walked us through the material. I also want to thank everyone who's been chatting in your questions throughout the webinar. We're about to address them. Just in general right now, in case you may have joined after We shared this at the beginning. Yes, this is being recorded, and yes, you will be able to review the recording and the slides later on. What we are doing for the webinar today and all of the core related webinars this week is that we're going to put everything together in one email. So later this week, you can expect an email in your inbox with both the recording from this afternoon's webinar and the slides from this afternoon's webinar, as well as other core related webinars that happen this week. We're just trying to keep everything together and not overload your already probably pretty filled inboxes. So those will be coming up shortly. So I am seeing a couple more questions come in. I'm going to start with the ones that have already come in, and then we will make our way through. All right, so give me a moment. Let me toggle back to my question list. Okay. Let's see here. So I think, I'm going to actually go a little bit out of order, but there have been a lot of questions about staff training and training for peers. And so someone asked when the staff training memo will be available, if the state is able to answer that question.
That is a great question. It is currently going through our sign-off process, so it will be available as soon as possible. I don't have a date, but what I can tell you is that the required training should be available through CPI by February 1st, and the memo will be posted by February 1st at the very latest, and then providers will have the provisional designation period. So they'll have time during provisional designation to complete those required trainings. There's nothing providers need to do at this point.
Great, thank you. And I think, Katie, that actually covers quite a bit. There were a couple questions about some of the topics that might not be required for peers right now, but will likely be contained in what's on the CPI LMS. So stay tuned for that memo when it's finalized and available, and a lot of the content will be on the CPI LMS, available shortly. Okay, jump back to the questions. All right, let's see here. I'm just jumping around. Okay, so someone is wondering, with CORE, is transportation reimbursable as a peer support? So I believe there was an question. Go right ahead. Yeah. Sorry.
No, I know exactly the point in the training when this question came up. So number one, I would say that there is guidance on this in the operations manual. So please make sure that you've read the entire manual. I believe it's under either the staff transportation section or the service location section. We can get that page number for you if you need it. But what we have said is that if a staff is transporting an individual, and this is true for any of the services, not just peer, and while transporting them, they are actively delivering a service as defined in the components, then that time would be billable. So transportation in and of itself, not billable. That is not a service component. If you're just driving silently in the car and not doing anything around skill development, skill building, companionship, peer support, not billable. But if you're driving someone to the bank and on the way to the bank, you are talking about what it is the individual will need to do there, how they might feel when they're there, how they can manage any symptoms that they experience when they're there, then that time is billable because you were delivering peer support. So I think that it's really going to be up to each practitioner, you know, how much service can you really deliver while you're driving, how stressful are the driving conditions, and you may need to make a decision on that day whether or not what you were doing was engaging the individual in a service.
Great. Thank you, Katie. All right, we're going to jump around here. We're going to find our next question. And I have seen, by the way, I know that there are quite a few questions about training. And so I'm not sure right now if now is the webinar we can address this on, given the staff training memo is still being finalized. But just know that all of your training related questions are going back to the state. So if we can't address them now on the webinar, please know that they are being shared with the state. Okay. All right, okay, so a couple questions about telehealth and peers. I think some folks are looking for clarification. Has the telehealth practitioner authorization now expanded to include peers? As a telehealth provider, I believe on the webinar we just described that we indicated peer support can be provided by telehealth.
Yep, so I want to be very careful that
Mhm.
everyone understand this answer. I am speaking for the Office of Mental Health. And what I say is true for OMH-hosted providers. If you are an OASAS-hosted core or BH HCBS provider, I'm actually going to ask Danielle to answer after me because we have separate regulations, unfortunately, okay? So for OMH, we are currently working on getting emergency regulations posted, which will include peer specialists as an allowable practitioner. And once those regs are posted, which as of today they are not yet, then you will be able to apply for permanent approval to do telehealth by peer specialists and other unlicensed behavioral health staff, paraprofessionals. As of today, we're still under the emergency, the federal public health emergency and the COVID-related guidance that's on our website. So as of today, if you are working under the COVID guidance, it's allowable. And moving forward, we're working on those emergency regulations that are not yet posted on the OMH side. And Danielle, I don't know if you want to add anything for OASAS. I'm not sure if Danielle is on mute or if she needed to step away, but we will make sure that they get that question, or if Danielle is able to jump in, that she's able to answer.
I think at the moment, if Danielle's not able to answer, we might jump to the next question, and then we can always circle back. All right, so we have gotten a question about, so we've talked a lot about core providers and whatnot, and I know this is not the topic today, but someone did raise if there will be core related trainings for CMAs. And I believe that is coming up. I think separate information has been shared with the CMA listserv. Katie, I'm not sure if you're able to provide any more information about that, but I do know MCTAC is working with the state on providing a training around core for CMAs.
Yeah, we have one training that has been, I believe, scheduled.
Mm-hmm.
And I don't have the date in front of me, but it is in December. And then we're doing a second one, December 13th.
Yep.
Yep. And that information will be sent via the MCTAC listserv, and then we will do a follow-up training for care management agencies in January.
Thanks, Katie. All right, just scanning to see other questions we have here. Okay. So a lot of these questions are related to where to find the core operations manual, where to find some of these materials and resources. And I do think if you scan the chat, our state partners have directly chatted out the link to the websites directly where this information can be found. So I would encourage you to visit that if you are looking for this information. So someone's asking, I guess, for clarification, if individuals and participants have to be HARP eligible to qualify for peer empowerment services under CORE?
That's a great question. So I would really encourage that anyone who's on this webinar, if you haven't listened in on the implementation overview that we recorded, please do go back and listen. So core services, all core services, not just peer support, but all four are available to HARP enrollees, so individuals who are enrolled in a health and recovery plan, and HARP eligible HIV special needs plan or HIV SNP enrollees. And at that time, those are the only individuals who are eligible for these services. So if you're looking at H codes, which are recipient restriction exception codes on someone's ePACES file or in psyches, you would be looking for H1, 2, 3, 4, 5, and 6. If they don't have those H codes, if they are not HARP enrolled, or if they are not HARP eligible HIV SNP enrolled, then unfortunately they cannot access core services at this time. I do want to briefly mention that the other piece of eligibility, which is covered in that other webinar, is the licensed practitioner of the healing arts recommendation. So you do need a licensed clinical staff who meet certain qualifications to sign off on basically a one-pager recommendation saying that the person needs these services and that it's medically necessary. So please do go back and review our previous trainings.
Thanks, Katie. All right, I'm just scanning. So another person is asking, I think, so their question is directly for the one-on-one time. Does that mean that members are not to have a family or friend included during the peer support services?
So what that means is when we talk about ratios like 1-to-1 or 1-to-6, we're talking about the number of staff to client ratio. So the 1-to-1 means 1 staff, 1 client. It means that you cannot have 1 staff and 2 HARP members. That would be considered a group. And unfortunately, we don't have the availability of groups under core peer support. If someone has a family member present, that doesn't make it a group. There's still only 1 client. Your client is the HARP member. So they can have a family member present or a friend or a supporter because the 1 refers to the singular HARP enrollee or HIV SNP enrollee.
Thanks for clarifying that, Katie.
Mm-hmm.
Okay, let's see here. So someone is asking if they are already a designated HCBS provider for peer services, what will they need to do to become designated for core?
You don't need to do anything. If you are currently designated for peer support under adult BH HCBS, you will be receiving a provisional designation letter from OMH and OASAS. In about the next month, we have said publicly that we will get those out by January 3rd. So you'll have a full month before the core go live that you have this letter in hand. And the provisional designation letter will be effective February 1st through July 31st. And by July 31st, so you'll have a 6-month period, you will need to do some things in order to get full designation under core. And that's things like updating the mental health provider directory system. You'll need to sign an attestation saying that you understand the operations manual, that you understand the staff quals. Your staff will need to complete the staff training requirements through the Center for Practice Innovation. But additional guidance is going to come out around that, and you'll get your provisional designation letters in about 4 weeks.
Great. Thank you, Katie. All right. This is a question in regards to the LPHA recommendation. Someone chatted in, will this be the responsibility of the core provider or of the referral source?
It is the responsibility of the core provider to ensure that they have an LPHA recommendation on file in the client's record. who completes the recommendation, that could be any qualified licensed practitioner of the healing arts in New York State. So if you're the core provider, you might partner with their outpatient clinician at a clinic or with their primary care doctor to get that paperwork signed. But at the end of the day, if there's an audit or a review and that piece of paper isn't in the chart, it comes down on the core provider. So it is not the referral source's responsibility, although they could be helpful in helping you get it.
Great, thank you, Katie. I'm just going to take a moment to kind of review all the questions that have come in. Again, all of these questions will be shared with the state, and we are really trying to keep it on track to the topic at hand. Let's see here. As I scan, I just wanted to invite my state partners, if there's anything, I guess, you would like to emphasize or clarify at all from some of the questions that have come in, anything else that you wanted to share about the content that we delivered today, as I search for our next question.
I'm seeing a question around the service bundles and how peer support can be used with other services. This is something that is briefly mentioned in the operations manual. We talk about flexible service design. So what I would say is you really need to read the operations manual together with the benefit and billing guidance, because what services an individual can receive depend on all of their other services. If you have a heart member who's not receiving any behavioral health services anywhere, then they could receive all 4 core services if the LPHA believes that that's medically necessary. And you could use all 4 services as a bundle to support that individual with their clinical needs, with their family support needs, their peer support needs, their psychosocial rehab needs. But let's say you have an individual who has a therapist at an Article 31 clinic and they're doing really well with that therapist, but they would like some support with navigating the community on their own. And so they might be someone who would get peer support and psychosocial rehabilitation only. Maybe they don't need the family piece. Maybe they don't need community psychiatric support and treatment, which is the clinical service, because they have that outpatient clinician. So it's going to be really tailored and individualized based on what the person needs and what their other levels of service are. So you want to make sure that you understand all of the restrictions around duplication of services. So another example of that is you can't have someone who is in PROS and receiving psychosocial rehabilitation. The great thing with peer support is that there are very few duplicative services in our system. So peer support can really be added into almost any other service. And the individual could benefit from that collaboration between the peer and any other providers. So I would just refer you to both the operations manual and the benefit and billing guidance for more details there. I also noticed a question around utilization management and prior authorization and concurrent authorization. I know that under BH HCBS, one of the common frustrations was that every managed care organization had a different process and a different timeline and time frame for authorization requests. So what you need to know for CORE is that during the first year, so from February 1 of 2022 to January 31st of 2023, there will be no prior authorization and no concurrent authorization. Your responsibility as a provider is simply to notify the MCO within 3 days of initiating the service. And if there's no issue with duplication of services, then the rest of that service planning process, where you determine the frequency, scope, and duration, that is between you and the individual to engage in person-centered planning and determine what is medically necessary. The MCO may do a retrospective review, or they might engage in care management activities If they see like an outlier where someone's receiving a very high level of service that's out of line with other individuals, they might engage in some care management or an outlier management process. But otherwise, all of that day-to-day utilization management, prior authorization, concurrent auth, that is suspended for 1 year while we work closely with providers and MCOs to define what that process will look like moving forward.
Thank you, Katie. Okay. I think, Katie, we've had some follow-up questions to that in the chat box. I'm not sure if we can speak to the specificity of those questions at the moment, or if that's something you'd like to take back, but I think there were questions about, just in terms of notifying the MCO. Within 3 days of initiating the service, does that mean, within 3 days of the first time you meet with the individual?
Yep, that is within 3 days of your first billable service, really, because that's how an MCO is going to measure it, is like, okay, you have a claim for February 1st, then you should have told me by February 4th, right, within 3 days. If you happen to meet someone at a health fair and you're not going to bill for that because you just met them at your table and then they're going to come in a week from now, you don't need to tell the MCO that you met them at a health fair. But within 3 days of your first billable service. You don't want to wait until you get to the point of an ISP, because at that point the person could be really heavily invested in these services. You might have met with them several times and they put all of that energy into developing a service plan, and you don't want to wait so long just to find out that there could be a duplicative service. What if this person is enrolled in one of the programs that you can't access with peer support? So you want to make sure that you're calling the MCO or notifying them using the service initiation form as soon as possible, just to make sure that there are no issues.
Thanks, Katie. And I think someone had a question in terms of, determining goals and medical necessity. Is that on the peer provider, or is that for the LPHA to work with the individual on?
So goals are determined during the person-centered planning process between the peer specialist and the individual. So that's actually different from BH HCBS, where the goal was typically set between the individual and their care manager before a referral was ever made. We learned that that didn't really work so well, because sometimes the care manager didn't even understand what it was that a peer specialist could or couldn't do, or what an appropriate goal might be. So under CORE, the goal itself will be determined during person-centered planning between the person and the peer specialist. Medical necessity is determined upfront by the LPHA as a part of their recommendation, and then on an ongoing basis by every provider. Just as you complete your progress notes, you're looking at, did I deliver a medically necessary service? And as you're reviewing every ISP, that's really the concept of the golden thread that you want to see in all of your documentation is the intervention still medically necessary? But on the front end, it's determined by the LPHA.
Thanks, Katie. Okay. Okay, so I think just kind of following up on this whole 3-day piece, someone is wondering if the peers contact the service providers. Is it the peer who contacts the service provider within 3 days? I believe is the question. And maybe I would ask, I'm not sure. You know what? Let me pause and say, if we could have a little clarification from the person asking the question, I think then we could follow up with the state on that one. I'm sorry, I didn't catch that as I read it aloud.
Yeah.
So I'm not sure if this is a clarification, but we did have another question pop in. Does the HCBS and core service provider need to contact the MCO within 3 days of the first billable service?
So HCBS and core will be two separate program models as of February 1st. So I'm only going to answer this question from the perspective of core services, because nothing has changed on the HCBS side. So if you're curious about how that works, then you would need to review the HCBS guidance and Medicaid Managed Care billing manual. For core services, the core provider is responsible for notifying the MCO within 3 business days of the first billable service. So if you meet with someone on a Monday, then by Thursday, you should have sent that service initiation notification over to the MCO. It's a very simple form. We've told all MCOs that they need to have a process for accepting these forms securely. And the form is on our website, on the OMH Core Services website. It's also part of the benefit and billing guidance, which is also on our website.
Great. And Katie, and also a lot of our state partners, I'm noticing a lot of questions that are more broadly core questions, right? They're a little bit more broad than specific to peer empowerment support. And so I'm wondering if it would make sense for folks who have questions that are about why some HCBS services are transitioning to core, why some are not, how this will work. There are some recorded webinars that the state has done. I know that are both they're on the MCTAC website. You can locate them there. I would encourage folks to visit those. I think besides the operations manual, which is a tremendous resource, the state OMH website, which has a ton of information, there are a few webinars that have happened within the last 2 months that contain a lot of valuable, I would say 10,000 foot level information, kind of broadly speaking about the change. Would you recommend folks kind of review that for these broader questions they have that aren't really specific to peer empowerment, or is there another resource you might direct folks to?
So I would really, really strongly encourage that everyone read all of the guidance on our website, review the MCTAC webinar that was posted in the comments on the implementation overview. And within the next couple of weeks, we're also going to be issuing our first version of an FAQ, of frequently asked questions, and we're going to keep that updated over the next couple of months. So the questions that we're not getting to today, we will make sure that we get to in that FAQ. So please do read through all of the guidance documents. They really do complement each other and should be read together, and review the implementation webinar as well.
Thank you, Katie. I could not remember the word for implementation just now, and I blame all of the turkey that's still digesting. So my apologies about that. So I want to thank all of our state partners as we start to wrap up the webinar today. I know that there were plenty of questions that we were not able to necessarily address directly, but maybe we took a little piece off. We were able to chip off a piece with an answer of. We tried to address all of the questions that we could today related to peer and core. Again, I just want to remind everybody that this recording, as well as the slides, are going to be made available. You'll get an email probably towards the end of this week that has, this information, the slides, the recordings, not only from today's webinar, but from the subsequent core webinars that are happening later this week. It'll be like a little core webinar digest. So I just want to, again, thank you all for joining, for sharing your questions, for our state partners, for reviewing this information and material and answering questions. And I just wanted to see if there was anything else our state partners wanted to say before we wrapped up the webinar.
We would just thank everyone for attending and for sending us your questions. We will incorporate as many of them as we can into the FAQ and continue to keep that updated. Please tune in for the additional trainings on family support and training, psychosocial rehabilitation, and community psychiatric support and treatment. And of particular interest is the person-centered planning and documentation webinar next week, where we're going to walk through some of the changes in documentation requirements. So please do keep attending these webinars, and we'll see you there.